Good. So now we have a full picture. You see how much more technology there's available for eye scan. We only have half of those machines in the New York office because with keratoconus we tend to do a lot more testing and analysis. But the numbers are very similar to what we saw there. We're just imaging them with different machines.
Mm-hmm. And he didn't have contact lenses only 2 days.
Mm-hmm.
Is that okay?
That's fine.
Because we didn't know
That's
that
fine.
he didn't need.
That's fine. It's usually significant for correcting regular myopia, but for correcting keratoconus, it doesn't affect it that much. The epithelium is irregular anyway. This is the skin of the cornea.
Mm-hmm.
This is not available in the US as a measurement yet.
Mm-hmm.
So we're imaging here the skin of the cornea, which appears to be very irregular. There's areas, the cold areas here that is very thin,
Mm-hmm.
and the hot areas, the epithelium is very thick.
Mm-hmm.
So this is nature's attempt to try and buffer the peak of the cone.
Mm-hmm.
So it thickens the skin around it and it thins the skin over it,
Mm-hmm.
in an attempt to normalize it as much as possible.
Mm-hmm.
But the good news is that our thickness is relatively good. I mean, our minimum thickness is over 450, as we talked about. This is a more accurate, OCT is a more accurate way to measure thickness than pentacam,
Mm-hmm.
than scientific imaging for keratoconus. We have, of course, the pentacam images here as well. And here we go. So, we're ready.
The thing he wanted to attend to.
What I was asking in terms of the recovery process is how soon afterwards I'll be able to put on some kind of corrective lens.
A week,
A week?
4 or 5 days, depending. Some
The
people,
prescriptive contact lenses or
Isn't
just-
it being corrected?
the prescription will change. Your prescription will be changing the first month. My guess will be that you'll be probably around the -2 area. -2.
Which is what does that translate into?
2 diopters of myopia, no
Okay.
astigmatism. So you'll be in that ballpark.
No astigmatism?
No significant astigmatism in the soft contact lenses.
Yeah.
When we measure for glasses, we always will measure a little bit of astigmatism, but with soft contact lenses, looking where you're at now, we're measuring now as +0.5 -4 diopters of astigmatism on your left, on your right, and +1 -425 diopters of astigmatism on your left. And this is similar to what you're wearing in glasses. In glasses, you're wearing +1 -3, +2 -4. It's very similar. So my prediction is with the Athens Protocol, we will taper the peak of the cone, and it will seem as if we're moving your keratoconus central.
Mm-hmm.
So that's, I mean, just to give you an idea, I just saw a gentleman that we did in January. So he's 3 months out, and his numbers look spectacular. Where is his numbers? Here he is. So this will give you an idea. This was the gentleman. He is 22 years old.
Like you.
This was in February. I'm sorry. We did him in February, and this is him today.
Mm-hmm.
So you can see the difference is dramatic.
Right.
If,
But he will be, because luckily he's going to be probably working.
Yeah.
An interesting work that he's been offered. But could he be able to put contact lenses
Yeah,
with
I think
prescription?
within a week or two we'll be able,
Good.
and we'll give you some trial lenses from now,
Mm-hmm.
because we can kind of guesstimate where you're going to be at. I think
Okay.
you're going to be around a -2.
Okay, the trial lens will be soft or GP?
Yeah, soft lens.
Okay.
And he will eliminate the astigmatism?
We'll reduce the astigmatism significantly,
That's great.
so he may be able to wear just regular soft lenses.
Yeah, because the astigmatism
Of course.
is the problem.
It's not only the astigmatism, it's how irregular the cornea is. The fact that the top half is different than the bottom half.
Right.
And the key number here, as we discussed in Europe, is the IHD, this number here. I'll put it in a circle for you.
Yeah.
This number here on your right eye is 127, on the left eye is 151.
Mm-hmm.
So we're hoping that we can drop this number to at least half.
Mm-hmm.
I mean, in the gentleman that we just saw, I can't promise you this, but in the gentleman we just saw, if you look at his IHDs, which is extremely impressive, he was 162 in February, and today he's 25.
Almost nothing.
This is one of the best cases I've ever seen. But this is a little bit of matter of luck. It's not just art and science. But this is a good example how much more normal his cornea is.
Now become.
So,
if you figured out kind of what factors tend to be lead to more success rates yet? Or?
well, we want to normalize the surface as much as possible, and the technology we're currently using, which is, we always use topography-guided.
Yeah.
First we started with the regular placido, then we used the pentacam, and now we use a special placido that also captures anatomy from your iris, and when you're under the laser, it adjusts the correction according to how your eye has probably turned a little bit under the laser. Because there's such a thing as excyclodeviation. It's a Greek word used in medicine globally, which means when we lay down, our eye usually rolls outwards a little bit, turns a little bit outwards. So our right eye turns a little bit counterclockwise, our left eye turns a little bit clockwise.
So they go like this.
So both eyes, no, they don't sway outside, they rotate inside. So if you don't take that into account, your laser treatment may be a little bit off center. So now this imaging device is able to image your eye when you're standing up, sitting rather, and adjust the treatment if your eye has turned a little bit when you lay down. So that's called cyclorotation adjustment. And we're studying this over the last few years, and we're seeing a dramatic improvement with applying this on top of whatever we did in the past. So it's a little technically complicated, but I think that this is the key element when you ask me what do you think matters the most. I think this has been the most fruitful thing we've been doing in the last 2 years. The procedure is a little bit painful the night of the procedure.
Yeah.
The procedure itself is very easy. You won't feel anything in particular that's tough or difficult. In the night, it'll be a little bit burning. It'll be burning, stinging, just one night. From next day, you'll be much more comfortable. You can walk around, do most things. The vision is not going to be very good. You'll be close to the 20/40 mark for a few days, and then day 4, we're hoping we can get rid of the contact lenses and get you the bandaged contact lenses and get you back into.
Well, 20/40 is not so bad. I mean, it's better than what I see right now without the lenses. So.
But it will be blurry, right?
It'll be blurry. The first few days will be blurry.
And he wanted to know about the exercise.
You can work out 5 days afterwards. Once the skin of the cornea heals, you can swim, you can sweat. Doesn't matter.
It's the exercise, the sweat. It's the
sweat that we're concerned with.
But at 5 days or 10? 10 was in the paper.
We say 10 days because by 10 days everybody has reepithelialized. But if we see you at day 4 and you have reepithelialized, meaning the skin of the cornea is healed, then you can go ahead and bathe and shower and work out.
Great.
But the average is day 4. Everybody is pretty much included in day 10.
Okay.
And in Greece, usually if we say 10 days, they usually keep it for 5 days. So if we day 5 days, they'll keep it for 2 days, which is not good. So the measurements look very good. The only thing I want to do additionally on Jonathan is a Cassini. Want to check a Cassini as well because we don't have it in Europe. So we want to do a Cassini map as well, and then we'll work out our your numbers.
Okay.
All right.
All right.
Everything looks good.